So I'll come to most important topic ITP. No entrance exam is without ITP questions. So I've taken from lot of textbooks and also articles extensively on ITP so that you can cover for both INACET as well as for NEET-SS. So ITP, acute and chronic ITP is now no more in the diagnostic paradigm. So now we classify ITP as immune thrombocytopenia. It's not immune thrombocytopenic purpura. Previously, we call it as idiopathic thrombocytopenic purpura. Now the terminology is immune thrombocytopenia. So it is classified as newly diagnosed, less than 3 months of diagnosis. Persistent ITP is 3 months to 12 months of diagnosis. Chronic is more than 12 months of diagnosis. So only remember the duration of immune thrombocytopenia, newly diagnosed, persistent, and chronic. So then remember what is the treatment of ITP. What is the pediatric ITP guideline says? Irrespective of count, even if platelet count is in the single digit, irrespective of counts, patient with minimal cutaneous bleeds, only clinical follow-up is recommended. So this is the latest American Society of Hematology ITP update. Please remember this. So the question will be on pediatric ITP child with platelet count of 5,000, 8,000, having no bleeds at all, no skin bleeds, or minimal skin bleeds like few petechiae, few purpura. So treatment is not steroids, IVIG or anti-Ds. Treatment is only close observation and clinical monitoring. In case if you want to give steroids for pediatric ITP because of extensive skin bleeds or mucosal bleeds, for example, epistaxis beyond 30 minutes, lot of gum bleeds or gastrointestinal genitourinary bleeds, then treatment is warranted for pediatric ITP. What is the recent guideline says? You give short course of steroids. Short course of steroid definition is not more than 7 days. This is very important. In pediatric ITP, we never give steroids beyond 1 week of therapy. So dose is 2 to 4 milligram per kilogram, maximum of 120 milligram can be given for 1 day. And only for patients with life-threatening bleeds, retropharyngeal, gastrointestinal, genitourinary, or patients with imminent intracerebral hemorrhage. So in doing those patients, we give triple therapy, IVIG plus platelets plus steroid. This is called triple therapy in ITP. And remember this, at what age rituximab is approved for ITP? It is 2 years and beyond. Is the age approval for rituximab, and indication for rituximab is only for chronic ITP in pediatrics. So once again, it's not approved for newly diagnosed or persistent, approved for chronic ITP in pediatrics. And at what age L-thrombopac, which is thrombopoietin receptor agonist, got approval? It's for age 1 to 6 years. Age beyond 1 year is the age for L-thrombopac approval. So we start with 25 mg. Age more than 6 years to 12 years, we can start with 50 mg. And this is also very, very important. What additional test is required for ITP diagnosis in pediatrics? Nothing. It is simple. Complete hemogram containing hemoglobin, WBC, platelets, peripheral smear is sufficient for ITP diagnosis. When will we do other testing? When we get alteration of total counts, high total counts, very low hemoglobin for age, like ITP with my minimal skin bleeds or epistaxis, we get only mild anemia. That too because of iron deficiency. If ITP children having macrocytosis or having high lymphocyte neutrophil ratio, or patients have atypical cells in smear. So in these patients, you perform bone marrow examination to rule out either aplastic anemia or leukemia in ITP. So otherwise, bone marrow is not universally recommended for any ITP diagnosis, pediatric, adolescents, young adults, irrespective of the platelet count. So when do we work up for other causes of ITP in pediatrics? For chronic ITP, remember, in patients, when platelets are abnormal beyond 1 year of diagnosis, then we do other investigation. What does the guideline says? Guideline says rule out antiphospholipid antibody syndrome, autoimmune lymphoproliferation syndrome, ALP syndrome, or combined variable immunodeficiency. These two are very, very common cause of chronic ITP in pediatrics. So it is ALPS, autoimmune lymphoproliferative syndrome, and common variable immunodeficiency. These two are common causes in pediatrics to cause chronic ITP. So what investigation we do for ALPS? We do double negative T cell receptor alpha beta cells. So this is done by flow cytometry of the peripheral blood. So remember what we do for ALPS, peripheral blood flow cytometry for double negative T cell receptor alpha beta cells. So remember this. For adults, what investigations are important? Apart from hemoglobin, WBC count and platelets, peripheral smear, retic count, DAT, HIV and HCV all are important first tier investigations for ITP. Please remember this peripheral smear, hemogram, reticulocyte count, direct Coombs test, HIV, HCV because direct Coombs test is important and retic count is important because we need to rule out concomitant Evans syndrome because adult predominantly comes with secondary causes of ITP. So always we have to rule out Evans syndrome as presenting future of ITP. And number two, retroviral infection. HIV infection, HCV infection can cause secondary ITP as a result of immunological destruction. So these two also requires special treatment rather than traditional ITP treatment. Hence, Evans syndrome, HIV, HCV should be done as a first tier investigation for chronic ITP in adults. So in adults, again, important MCQ is don't give steroids beyond 6 weeks of starting therapy. So children, 7 days, adults, only 6 weeks of therapy. So when adults have steroid dependent ITP or a chronic ITP, we give rituximab or we can give L-thrombopac or amiplastin. In main exam, if they ask you which is the most suited second line agent for ITP is TPO receptor antagonist because it lacks serious side effects compared to rituximab, and secondly, this causes sustained response. Then compared to patients on rituximab. Hence, the standard second-line therapy for chronic ITP is thrombopoietin receptor agonist, which is L-thrombopac and romiplastin, and not rituximab. So what are the problems with rituximab? Rituximab causes severe hypogammaglobulinemia because it's a B cell depleting agent and it causes progressive multifocal leukoencephalopathy caused by JC virus. So remember, these two are life-threatening complications of rituximab. And what are all the response numbers in ITP? Always remember these numbers just before the exam. So platelet count of less than 30,000, adult ITP requires admission. Whereas pediatric ITP, as I mentioned earlier, even if irrespective of counts, patient can be managed on OPD basis. So in adult ITP, platelet count of less than 30,000 is required for admission. Then what is the definition of response? Partial response is defined as after you start a patient on steroid therapy for ITP, if platelets are more than 30,000 and there is absence of bleeding, sustained for this point is important for exam. So what is the duration which is taken into account to call it as a response in ITP? It is 1 week or 7 days. So partial response is nothing but after you start a patient on steroid, if platelets become more than 30,000 and the response is sustained for at least 1 week and the absence of bleeding, all three criteria should be fulfilled to call it as partial response. And what is complete response? Again, absence of bleeding, 7 days duration, and platelet more than 1 lakh is called as complete response in ITP. What is remission in ITP? Remission is when platelets are more than 1 lakh for 1 year without treatment. That is called ITP remission. That means ITP is cured. So that is defined as remission in ITP. So again, I want to reiterate same point. Platelet count less than 30,000, admit the patient, and admit the patient. Platelet count more than 30,000, you can manage the patient on outpatient department. Similarly, I mentioned guidelines clearly recommend against prolonged course of prednisolone. So exam they will ask you what is the maximum duration of prednisolone given for ITP. It is not beyond 6 weeks of therapy. So what is the dose? Either prednisolone or dexamethasone. Both can be given for ITP. Preferred is always prednisolone. If patient is having prednisolone or dexa failure, then you give second line therapy as either rituximab or eltrombopag. So this is better, followed by rituximab and also splenectomy. Splenectomy is recommended only beyond 1 year of diagnosis. So at least after 12 months of chronic ITP, patient is refractory to steroid, IVIG, second line therapy, then you go for splenectomy because splenectomy can cause 50% remission in chronic ITP patients. So for patients with this threshold, mainly patients on antiplatelets or anticoagulants, or elderly patients beyond 60 years of life, or ITP patient, even if platelet count is more than 30,000, awaiting procedures. So in all these patients, you can exceptionally treat them on corticosteroids. Otherwise, tradition is more than 30,000, don't treat. If you want to treat those exceptional patients, if patient is on aspirin or clopidogrel or on heparin, warfarin, so those patients we try to keep a cutoff of 50,000 to prevent spontaneous hemorrhages. Or patients who is elderly, more than 60, because elderly patients are more frail and has more chance of bleeding. So those patients you can treat them with steroids. Or any patient who is planned for endoscopy or any hernia surgery. So for those patients, cutoff is different. For major surgery, we take cutoff of 50,000. For neurosurgical or ophthalmic surgery, we take count of 1 lakh. Please remember this.